Good afternoon, everyone. My name is Huang Kangmo, and I'm honored to present our recent study on behalf of the Jining Hospital team. Today, I'd like to share our recent study titled Angiography-based hemodynamic features, predict stroke recurrence after endovascular treatment for intracranial vertebrovaginal atherosclerosis. Thank you for being here. Here's a quick overview of today's talk. I will first explain the background, the methods, and finally, our main findings. Intracranial atherosclerotic stenosis, or ICAS, is a major cause of ischemic stroke in Asian populations, especially in China. Studies showing it accounts for around 47 to 51% of ischemic strokes, or TIA, in Chinese patients. The two main mechanisms are reduced blood flow, hyperperfusion, and artery-to-artery embolism, where plaques or clots travel downstream. In terms of treatment, we have three main approaches. First, medical therapy is the standard. Second, surgical bypass is rarely used due to invasiveness. Third, and the most relevant here, is endovascular treatment, mainly angioplasty and stentin, which can restore blood flow. However, its safety and effectiveness, especially in the vertebrovaginal system, remain controversial. Endovascular treatment for ICAS began in the 1980s with balloon angioplasty. The wingspan stent got FDA approval in 2007, sparking interest. But trials like Sunrise and VET showing the high complication rates and no clear benefit of medical therapy. More recent studies like WAVE showing that in carefully selected patients, stenting can still be safe and effective. So patient selection is key, and that's what our study focuses on. Stenting, also known as PTAS, can be helpful in patients with recurrent events or who don't respond to medical therapy. But even after successful PTAS, stroke recurrence still happens in about 8 to 8.5% of cases within 1 year. This shows that treatment alone isn't enough. We need better tools to evaluate risk and guide follow-up. To improve outcomes, we need ways to evaluate patients before and after PTAS. And more importantly, we need to identify who is likely to have stroke recurrence. This unmet need became the central motivation for our investigation. Computational fluid dynamics, or CFD, is one way to study blood flow in ICAS. It provides detailed data like pressure and wall shear stress, which are linked to stroke risk. For example, patients with low pressure ratio and high wall shear stress ratio have higher recurrence rates, but CFD is complex, time-consuming, and hard to use in clinical settings. We aimed to explore whether a simpler angiography-based method like QDSA could provide comparable hemodynamic insights in a more practical and clinically feasible way. QDSA derived time density information directly from routine DSA images, avoiding the need for complex modeling like CFD. Prior studies in anterior circulation, ICAS, have shown that QDSA can reflect both stenosis severity and delays in cerebral circulation. However, its application to posterior circulation ICAS remains underexplored. Our study aims to fill this gap. Next, I will introduce our study objective. Our objective was to use QDSA to extract hemodynamic parameters before and after PTAS and to evaluate their value in predicting stroke recurrence. We focused on posterior circulation ICAS, aiming to find simple angiography-based indicators for risk stratification. Let's now move on to the methods section. This was a retrospective cohort study where we used QDSA to measure time density changes before and after stenting, and analyzed the relationship with long-term recurrence. We screened 307 patients treated with endovascular therapy. After applying inclusion and exclusion criteria, we analyzed data from 137 patients with posterior circulation ICAS who underwent PTAS. This cohort formed the foundation of our QDSA-based analysis. Our inclusion criteria were age greater than or equal to 18, 50 to 99% non-occlusive ICAS in the vertebral or basilar artery, PTAS performed more than 48 hours after symptoms onset. We excluded patients with impaired consciousness, device failure, poor image quality, or loss to follow-up. This criteria ensured consistent image quality and meaningful hemodynamic evaluation. We collected clinical data, including demographics, vascular risk factors, laboratory data, procedure details. This helped us control converters and identify potential predictors of recurrence. We used Atlas shows to create time density curve from the DSA. Key parameters included TTP, time to peak, or AUC, area under the curve. These reflect flow speed and the volume. We also used color-coded maps to make it easier and visualize perfusion changes across the vasculature. Compared to CFD, QDSA is faster and easier to apply clinically. We focused on TTP and AUC for predicting recurrence. Next, we defined 8 regions of interest, or ROIs, along the vertebral basilar artery. ROIs 1 to 4 were placed from the proximal vertebral artery to the basilar artery, providing an interview of the inflow. ROIs 5 and 6 were set 5 mm and 10 mm between the stenosis. ROIs 7 and 8 were set 5 mm and 10 mm after the stenosis. This design helped us evaluate pre- and post-stenotic hemodynamics. This slide shows representative QDSA maps before and after PTAS. On the left, we can see slower contract clearance before treatment, evidence from flatter time density curves and delayed outflow. On the right, after PTAS, the curves become steeper with faster inflow and outflow, indicating improved perfusion. These visual changes supported the value of QDSA for real-time evolutions. We used two relative parameters, RTTP equals TTP distal minus TTP proximal, showing delay cross stenosis, RAUC equals AUC distal over AUC proximal, reflecting distal flow. After PTAS, decreased RTTP and RAUC suggest faster, more efficient flow. These indicators helped compare patients and track treatment effect. Patients were followed at 3, 6, 12 months, then yearly. Primary endpoint, recurrent stroke confirmed by imaging or symptoms. Secondary or recurrent ischemic events, including TIA. These outcomes helped assess QTSA's predictive value. Let's now take a look at the results. Here are the baseline characteristics of our patient cohort. In total, we analyzed 137 patients, 111 without recurrence, and 26 who experienced recurrence during follow-up. Compared to the non-recurrence group, patients with recurrent had a higher rate of prior TIA and lower HDL levels. However, these diseases did not reach statistical significance. Median follow-up was 42.6 months. After PTAS, RTTP significantly decreased, showing faster contrast arrival. RAUC 3/1 and IUC 4/1 significantly increased, reflecting better distal perfusion. Together, these changes indicate improved hemodynamics. QTSA captured treatment response effectively. We focused on RIS 5 and 8, pre- and post-stenosis. In the recurrency group, post-PTAS RTTP 8-5 and RAUC 8/5 were lower than the non-recurrence group. The differences were not statistically significant, but showing a trend. These regions may need close attention in future research. We built 3 Cox models: Model 1, clinical factors only, TIA history, high NLR, and low HDL were risk factors. Model 2, hemodynamic parameters only, RTTP 4-1 was a risk factor, RTTP 8-5 and RAUC 8/5 were protective. Model 3, combined clinical and QTSA parameters. This shows that combined clinical and QTSA parameters improve prediction of stroke recurrence. Kaplan-Meier curves showed patients with higher pre-PTAS RTTP 4-1 had more recurrences. Patients with lower post-PTAS RTTP 8-5 also had worse outcomes. These findings suggest RTTP is a useful marker, both before and after PTAS. We compared model performance using ROC curves. Model 3 compared clinical and QTSA had the highest AUC 0.817. Model 1, clinical only, had AUC 0.703. Model 2, hemodynamic only, had 0.808. NRI and IDI showed significant improvement after adding QTSA features. QTSA clearly improved prediction accuracy. We did subgroup analysis by age, stroke history, stenosis severity, and vertebral artery dominance. Across all groups, QTSA markers were associated with recurrence. No significant interaction was found, indicating that QTSA performed consistently in different clinical settings. In summary, pre-PTAS, high TTP, and low post-PTAS gradient were linked to recurrence. Adding QTSA improved the prediction. Further prospective studies are needed to validate QTSA's clinical value. That's the end of my presentation. Thank you for listening. I welcome any questions or suggestions. We hope QTSA can support better clinical decisions.